We're going to talk about some of the forms and record keeping that we use for our surgical patients here in the hospital. So I'm going to start by showing just a medical condition record. We're switching over to be paperless, so we do scan in a lot of documents and enter things directly into our computer system, the software Avamark. So we do have Gracie pulled up here. She was a patient we had today with just some surgical notes written in there. So now I'll go over and do our actual paper forms, most of which get scanned in to the computer at the end of the day. So we have our procedure estimate and consent form, which goes over the cost of the services that we'll be providing today, and then has the owner sign and give their phone number to call, along with emergency protocols that we should perform that they would prefer if needed, and then just their phone number so we can reach them if needed. I also have her chart here, which is her permanent record, and we're scanning things in and transitioning everyone over to be paperless. So it looks like it doesn't have much in it, but it does have her original health form. So we can see her signalment. She's a Yorkie, born in July of 2011. So she is over 6 years old. And she was just here for a dental procedure. No real medical concerns per the owner. She just needed a dental cleaning and some tooth extractions. So an otherwise healthy female spayed Yorkshire Terrier. So in addition to her permanent record there, we also have the anesthetic consent form, which also goes over, especially in her case, in the instance of a dental cleaning, they agree to teeth extractions that the doctor deems necessary. We also will be doing, or we did, lab work for Gracie this morning because she's older than 6 years, so that is protocol in our clinic. We also ask about microchipping and get their signature and phone number again, and how they want their updates, so they can have text updates if they like. So this is good because it shows that the owner understands that we're going to be doing pre-anesthetic blood work. It's also on their estimate, so they're aware of the charges that they'll be faced with when they come pick up their pet, and it won't be so much sticker shock when they arrive. And of course, we always call if anything is needs a little bit extra. So we also have some forms of identification. We have this sheet that is on their cage when they stay here, so we know we have the correct patient. This one is all filled out correctly when we gave the pre-medications, so that anyone who's walking by the cage might know why the patient is so sedate if they're not immediately taken into surgery. It also has the induction agent and then medications that we're giving during surgery to help with pain or sedation. So we have that both tracks, their vitals, who they are, what doctor's in charge of them, catheter placement, what they're here for, and their vitals when they came in the morning. And then this is just an example of a collar that we would print out for her. This is just the example size, but it is a collar that we put on all of our dogs and cats that are in hospital. So it has our phone number on it, the clinic, in case they were to escape, any allergies they may have, and then their signalment as well. So a Yorkshire spayed female, 7 years old, so that we know we have the correct animal when we're going into surgery. We have the blood work that we ran on her today. So this is an example of our Chem 10 with our CBC. So we do this for any patient that is over 6 years old. And as they get older, we'll do a senior profile that we send out to the IDEX lab. So this is just one example of the blood work we would run. Other examples could be, if we would need radiographs for a procedure that maybe is a fracture repair, ultrasound, if we're worried about, liver size or spleen issues or anything like that, or other diagnostic tests we could do. But typically for just a dental or a spay or a neuter or something pretty straightforward, we will just do our normal blood work that we run in-house. Which, of course, I guess I should go over why that's important. We want to know how their liver, kidneys, etc. are functioning before we put them under anesthesia, since a lot of those drugs are metabolized by those organs. Also to get a sense of dehydration, anemia, electrolyte balance, all that. So we know we have a safe anesthetic event in front of us. So something else we do here is some crash drugs. So if anything were to happen, what we would need to give her if she was having some sort of negative anesthetic event. So that's just something else that we print out for every patient based on their weight. And then if we needed to give atropine or something quickly, we could do it really fast without having to calculate a dose. So that goes with him to surgery. We have her anesthetic paperwork here, as well as just notes on what else we were going to do. So she was getting a lepto vaccine, updating the owner with text messages, and she was getting a laser treatment afterwards. It has all of the drugs we gave so that this becomes a part of her record, and we know exactly what we gave, when we gave it, how we gave it, and who gave it, in case any adverse effects come up. And then there is some monitoring. We also use monitors that record automatically, so our monitoring looks slightly lax, but there is a printout of all of her vitals throughout the entire procedure that we scan into the file as well. And then we send home a little exam report card with them. So that has her weight history on there, and then kind of an exam, but it was brief because she had just been examined and determined appropriate for her dental. So that's a little abbreviated. And then down here, her discharge instructions. So this is what we'll send with the owner as well, just to let us know if she is having vomiting or diarrhea, persistent lethargy, instructions about feeding. She did have a lot of extractions today, so she may be a little sore in her mouth. So things for the owner to look for that would be unusual, you know, excessive vomiting, diarrhea, lethargy, not eating, not drinking, not urinating, not having a bowel movement. Anything like that could be cause for alarm, and we want the owners to know that. So, and also just their activity to keep them a little bit restricted because they will be, you know, drowsy after having anesthesia. So not to let them run in the park this evening, but maybe just stay inside and take it easy. There's also the medications that she went home with today. So minoxidil, she's just a little dog, so it's a small dose, 0.13 cc every 24 hours until it's gone. And then the indication to start tomorrow, because she was given a sub-Q injection of meloxicam during surgery to help with inflammation. So she does not need to start that medication until tomorrow. So the owner knows what to look for and when to start the medications. And then one thing I didn't go over was when we checked in the patient, just kind of going over the actual procedure with them. So in the case of this dental procedure, I think a lot of owners don't necessarily realize that it is a full anesthetic procedure. So to just really make that clear that they are going under anesthesia, that's why we want to do blood work beforehand, especially in the case of an older patient. We'd like to do it for every patient. And then, you know, possible effects of that. And then also the procedure itself, a dental cleaning in some cases is just a little scale and polish, but in some cases can involve, you know, over an hour of anesthesia with extractions that can leave the patient kind of sore. So it's good to go over that. You know, if it's a spay, just describing the fact that it's an abdominal incision that will be closed surgically. You know, if it's a neuter, it's an incision also that needs to be, you know, treated with respect afterwards, and have an e-collar on your patient so that they can't mess with their incision and that kind of thing. So kind of going over discharge instructions and what to expect when the patient is dropped off can really help put the owner in the right mindset for when they come to pick up the pet, and then you maybe don't have to go over quite as much with them, and they understand what their surgery was. So those are some of our forms and conversations that we have with the owners when they drop off their pets for surgery. And that's it. Okay, so we'll show some different restraint methods for restraining for a blood draw. So if you need to restrain for the cephalic vein, if your patient's standing or laying down, either way, you just want to kind of get their head controlled by your arm. And then you want to have their foot out for the person who's drawing blood, and then you just want to squeeze at the top of the leg and do a twist. And then the person who's taking blood can use alcohol to visualize the vein better if they need. For a jugular vein, if they're sitting or standing, usually they're sitting up, which could make this easier. Hey, come on. How about, buddy? Yeah, good boy. Now come here. You can stand if you want. But either way, you can straddle the patient if they're big, but the main idea is just to hold up and straight, have the head straight and hold up as much as is needed for the person that's drawing blood, and they can give direction if they want the head raised or lowered at all, just so they have access to the jugular vein. And then for the saphenous vein in a dog, again, just stabilize the head as much as you can. It may require two people if you have a patient that's not really amenable to that. but you will want to just hold off down here just below the stifle joint. And you can see the saphenous vein here running, pop out there, so the person can draw blood from that vein if they need to. So as for applying a muzzle, if you have someone else to hold the dog, that's fine. Our patient is pretty compliant, so he's a good example. But typically you want to come from behind. Make sure with your muzzle that you have it stretched out already so you don't have to scramble if it's too tight to then try and like loosen the buckle and you have a dog meanwhile that's trying to bite you. So you want to usually go from behind them so they don't see it coming. Drape it over their face, flip it quick, and tighten it down as much as you can. As tight as it'll go so that they can't get it off. So that's a muzzle. That one's a little big for him. I would have probably gone for a smaller one if he was really fighting it. And then for an e-collar, I have one ready to go. We use stretch gauze here to kind of tie him in place. It also gives something to tie to the collar if you want them to have it on, you know, long term, which usually you do. This one's just going to protect him from chewing his catheter today. So you just slide it over, and then you have your gauze ties you can use to tighten it down, or to tie to their collar if they're wearing a collar. And there we go. Okay, so we'll show how to put a patient back into a cage. Come here, buddy. You open up their cage. And I know it's hard with that cone. If they need a little assistance with the cone, you can give them that. Hop in. I mean, just kind of a gentle guidance is really all you typically need. Instead of forcing them in, they usually will want to go in on their own into their cozy little bit. So there's that. Okay, so now we'll be taking Henry out of the cage. So if it's a big, you know, boisterous dog, you can always block the cage door with your foot or your knee if they're like jumping up on it, or get down a little lower so you're ready to brace for them. But he's pretty calm. So I have my leash, and I'm just going to slip that behind his e-collar. Hi, buddy. You waking up now? So once you have him securely on a leash, then he can come out of the cage. Is it hard with your cone? There you go. There we go. And that's it. He's out. Okay, so we have here a pre-surgical patient. He's here for a mass removal today. There's a little mass on his ear, and then as we do the exam, you'll be able to see the larger mass on his side. So you do want to do, you know, just a general assessment of health. This cat is actually being treated for an upper respiratory infection, and he just sneezed before the video started, but he's still been approved for surgery by the doctor. So you may see a sneeze during the video, and that is actually for him normal, but normally for a pre-surgical patient, you would need to alert the vet that will be doing the surgery and let him know that things don't seem all well. So there is a little bit of clear nasal discharge coming out right now. So you just want to check eyes, nose, ears. Make sure there's not any debris in the ears. His ears look pretty clean and good. His eyes are clear. You can get in and see in the mouth a little bit. Look for any ulcers on the tongue, any you know, loose teeth, or obviously infected looking teeth, or just the general condition of the mouth. Moving on down, we've already placed a catheter in him. You can kind of just assess mobility in the room a little bit. And then if we can get him to stand up, we can listen for his heart rate and respirations. And I have a little form over here too that I'll be writing everything down that we use for all of our surgical patients. So we'll see if we can get him to be still-ish. You good there? That's okay, buddy. So I've got the stethoscope kind of on his left side under where his elbow would kind of meet his body wall. His heart rate's pretty fast, but he is kind of nervous. And once I've got a good feel of it and he's still, I can look at my watch and count for 15 seconds and then multiply that times 4. So here we go. He's also purring very loudly, which makes it a little more challenging. So I've got about 40 beats in 15 seconds, which comes out to about 160 beats per minute. So I can write that on our form over here for his pulse rate or heart rate. Listening to his respirations. You want to listen on both sides and just make sure the lung sounds are clear. Again, he is being treated for an upper respiratory infection, so you could potentially hear a little bit of wheezing, although there shouldn't be much for an upper respiratory infection. His lungs actually sound really clear, and I could hear him on this side as well. It's a little bit hard for me to hear his lungs also because he does have this really large mass on this side that's going to be removed today, so that is making it a little more challenging to be able to get all the lung fields, but hopefully after that he'll be feeling better. While we were listening to his heart rate, I was counting respirations as well, and then on this side as well, it came out to about 15 respirations per 15 seconds. So that comes out to what, 60 respirations per minute, which is a little high. He is pretty nervous. He's purring a lot, making listening a little harder as well, but his heart and lungs do sound good. His heart doesn't have any like whooshing or any abnormal sounds to it. It has a really strong rate. It's even. So not too worried about that. His skin is a little flaky and dry, so that's just kind of something to keep in mind when shaving and stuff, to make sure that everything's clean and good before we start surgery. And then the last thing we'll want to do is take a temperature on him, and you want to kind of save that for last because cats are really not a big fan of that. And so saving it for last means at least you got everything else done first. So we'll go ahead. We have our temperature or our thermometer ready with a little bit of lube on it, and we're just going to take that rectally. Good job, Betty. Okay, so he's at 101.6, which is normal for a cat. It's actually in good range. So he looks overall healthy and good, other than the known upper respiratory infection. We'll bring up his progress to the doctor that'll be doing surgery, just so she knows, you know, he did sneeze this morning. But otherwise, he should be good to go for surgery. The ASA grade for our cat we just did the exam on, I would give a PS2 since he does have a little bit of an illness going on, but it is just an elective procedure and he's otherwise healthy and not extremely old. He's 12 years old and a little bit of upper respiratory, but a PS2 should be fine, and we will change our anesthetic protocol to fit that need. Okay, so we'll be doing our pre-anesthetic evaluation on our little friend here who's here for a dental. So much like with the cat, you just kind of want to start at the head and work your way down. So she is looking really good today. She's quite hyper. You want to look in her ears, make sure those are looking clean. No concerns to alert the veterinarian about. They look really good. Her eyes are clear and bright, no discharge. Her nose looks good. I haven't heard any sneezing or coughing from her, and nothing was reported from the owner. She is going to have a dental today, but it's always good to just kind of do a quick look in the mouth if you can, and if you notice anything especially alarming, you can alert the vet, but we can also wait till she's under anesthesia since she has been looked at recently for dental disease, and she's not super compliant about that. And then you want to listen to her heart and lungs and get both the heart rate and just listen for any abnormalities. So swooshing-ish sounds in the heart, if it sounds like there's any sort of arrhythmia, and also just any crackling in the lungs or wheezing sounds. So.
9:30 appointment, ready in room 4. Thank you.
You can start on the left side, kind of where their elbow would meet their body wall to find the heart. She has a really good, strong heart rate. Just in listening, I don't hear any missed beats or whooshing sounds or anything that would indicate any sort of heart disease. She's a little bit older. She's about 9 years old, so definitely want to listen for things like that. So you just look at your watch, time 15 seconds, count the beats, and then times that by 4. Hi. So she's at about 20 beats, 25 beats in 15 seconds. So times 4 is about 100 beats per minute. And you can also listen to her lung fields. You want to find a few different spots on the body wall, both dorsally and ventrally. and on both sides of the body, just to really listen and make sure there's no abnormal breathing noises. But she sounds good there. Respirations were at about 7 to 10, say 10 per 15 seconds. So times 4 is 40. She is pretty excited and wound up, so it's not super abnormal for her to have kind of a higher respiratory rate. And then just kind of moving back, along the body. She is having a little mass removal today that we went over with the owners. That's on her belly. So I've outlined that on her paperwork so we can tell the vet who will be performing the mass removal how big it is, where it is. And then the last thing we'll want to do is get a temperature on her. And we have our thermometer ready. Are you so excited? This is not very exciting, but you're doing good. Okay, she's at 101.3, so that's within normal range for her. So no major problems noticed for her. I would probably give her an ASA grade of like a P1. She's a little bit older, but she's healthy otherwise. She's had blood work done recently that all was good. I think she would be a really good, easy candidate for anesthesia and surgery today. Okay, so we're going to draw blood from the cephalic vein now. Just enter in at a slight angle, pull back on the syringe. You may have to readjust, but there we go. Okay, so now we'll pull blood from the jugular vein. I'm holding off down at the thoracic inlet. It's a very rolly vein. There we go. Okay. Okay, so we're going to draw blood from the saphenous vein of our canine patient. I'm going to use a little bit of alcohol just to better see the vein. I have someone holding off the vein above. You can see it pop out there. Just enter in, bevel up. There we go. So now we will draw from the cephalic vein of our cat. Again, you can use alcohol to help visualize the vein. Have someone hold off above for you. And then stabilize with your thumb. Put the needle in, bevel up. And doesn't have great blood pressure right now because he's been anesthetized for a while, but you can see the basic principles of the blood draw. Okay, so we're going to get blood from the jugular vein of our cat here. I have it held off down at the thoracic inlet, and you just want to enter with the needle, bevel up. And there we go.
Blood.
All right, so we're going to draw blood from the medial saphenous of our cat. So it's helpful to have someone occlude the vein, and you just want to insert the syringe or the needle with the bevel up. You can stabilize the vein with your thumb. Pull back on the syringe until you hit some blood. There we go. So there we go. Okay, so we'll go over some of the minimum databases required to ensure good patient care when going under anesthesia. So the book describes, 5 minimum databases. So one is PCV, packed cell volume. A higher PCV could indicate dehydration. A low PCV could indicate any problems with red blood cell production or red blood cell destruction, any sort of like autoimmune blood disorder that could be going on with your patient. That would be good to know before anesthetizing them. The book also requires or suggests as a minimum database getting a total solids reading, so you can know kind of the protein level in the blood, see if there could be any like liver abnormalities or things like that going on. Another one is blood glucose. So that can indicate, low blood sugar or high blood sugar if you're having like a diabetic patient. And also just kind of general pancreatic function can be determined by getting a good blood glucose reading before going under anesthesia. One more is BUN, the blood urea nitrogen. which can indicate renal function. So a high BUN would indicate that urea might not be being excreted well by the kidneys. So the renal function may be compromised a little bit for that patient. You'd want to know that, since so many anesthetics are metabolized by the kidney and the liver. Another one you want to check for is the ALT. Again, a high ALT could be indicative of liver damage. So since you have the drugs metabolized by liver and kidneys, you want to make sure that those are minimally functioning at a good level. In our practice, for any pet that's 6 years or over, we do require at least a Chem 10, so that tests for all of those that were just discussed, as well as some other pancreatic enzymes, and we test electrolytes as well. For any patient that is 8 or over, we will do senior blood work, so that tests for 27 different chemistries, as well as thyroid, and does a urinalysis as well. So those are our minimum databases before going under anesthesia here in our practice. So additional databases that could be needed if you find any abnormalities, or if the patient is presenting for a different kind of surgery that maybe you wouldn't normally be doing, such as a fracture repair. You'd need to take x-rays. If you suspect a foreign body, you would want to take x-rays. For a cystotomy, you would want to take x-rays to see how many stones might be in the bladder. So there's a lot of reasons you could take x-rays, as well as ultrasound for all of those ones mentioned. A foreign body or cystotomy would be good to check on the ultrasound, as well as if you suspect a spleen mass or an enlarged liver or free fluid in the abdomen. Those are all reasons that you would want to do an ultrasound before doing surgery. If you have an older patient or one that's just kind of generally sick, always you want to do kind of the maximum amount of blood work that you could do. For us, that's sending a senior blood work panel out to IDEX, which includes a urinalysis, kind of discussed in the minimum databases as well. Another thing you could do an ECG if you suspect heart problems and you want to get that checked out before going under anesthesia. Another one could be if you're doing mass removals and you want to know what kind of masses that are being removed, so the vet knows how wide of margins to take, how deep to go, what they're kind of dealing with. You can do a fine needle aspirate to kind of at least get a baseline guess as to what the cells are, or even have a preoperative biopsy done to send to the lab and have them assess what kind of mass it might be that you're going to take off. So those are all various other tests that you can do before doing surgery based on patient presentation and condition. So as for an appropriate anesthetic protocol, for most of our patients here in this practice, we do a pre-medication with Torb and midazolam to provide both pain control and sedation. Patients are usually induced with alfaxin and maintained on sevoflurane in our practice. Those can vary based on age. Those are for generally healthy animals that are easy to get along with. For example, today we did have a cat that was fractious. We weren't able to safely get it out of the carrier to put in an IV catheter. So in that case, that cat did have a TT Dex injection IM, so that she could be sedate enough that we could intubate her and then maintain her on Sevo. So there are differences to our protocol. That is one we use today for the safety of our staff. And that also provides good sedation and pain management. She was here for a dental, so if she had had extractions, more pain medications could have been potentially given perioperatively, maybe an injection of anti-inflammatory or something like that. But typically, yeah, we do an IV induction and then maintenance on sevoflurane, but it can depend on patient stability and handleability. All right, so I'll be making an entry into our controlled substances log for T-Lizol for one of our cats that's here for a dental today. So you just want to follow along in the book. Today is March 4th. We put our patient's name. Her name is Nessa, in quotes, and then we put the full owner's name as well. So this is J. Tressler. So that we have the last name and the first name of the owner and also the pet's name. The species is a feline. The name of the practitioner giving the order is Dr. Nicole Savageau. We just put initials here for NS. She will come and initial the box saying she has administered it when it gets administered, so you leave that blank for now. The previous balance is 10.915 mils. We are going to be giving this cat 0.12 mils of Tilazol. And then you just want to calculate the difference. So 10.915 minus 0.12 gives us a new balance of 10.795 mils in our controlled substance log for Tilazol. All right, so we'll be going over the various parts of our anesthesia machine. So here we have our oxygen tank. We use the big H tank, and it is on, and it was recently replaced, so it's on full. There's also the flow regulator here that just brings down the pressure a bit, so it's not coming out full blast. So this actually, this is going into the wall. I'm going to show you an anesthesia machine that we use on the other side of this wall. So then here is the line of the oxygen coming out of the wall into our anesthesia machine. So the line goes up to the flow meter, and you can turn that on and see your carrier gas flow. You can turn that up usually between the 0.5 and the 2 liters per minute. It measures oxygen flow in liters per minute, and you usually don't want to go over 2 in most patients. In addition to the flow meter, we have, that goes over, the gas goes through to the vaporizer. We use SIVO here in our clinic. We do a lot of exotic surgery, and it tends to be a little easier on the respiratory systems. So you can check the meter, and you can see the little ball in there showing that it's full. SIVO goes from 0 to 8. We run most of our patients somewhere between 2 and 5 on SIVO to maintain. So the vaporizer is what the liquid anesthetic goes into. So you pour the liquid sevoflurane in, the oxygen flows over that, and it vaporizes it. So then there's an oxygen and SIVO mix that goes to the patient and enters the breathing circuit. So after the vaporizer, you can see the inhalation and exhalation valve. So on this side is our inspiratory valve, and you would see that little flapper flap up when the patient breathes in, and on the other side is the expiration valve. So when the patient breathes out, you would be able to see that flap move as well. You can also see our pop-off valve up here, so that can be closed. It's difficult to close. There's also a button on the back so that you don't have to worry about it potentially staying closed. You can just hit that button if you need to manually ventilate for the patient, and that will temporarily close it so that you can give a breath safely, and it will automatically reopen so you don't have to worry about the pressure building inside the patient's lungs. So the pop-off valve will build pressure within the system if it's closed. You can see that on the regulator, which measures the amount of pressure in the system, also called the manometer. So that shouldn't go above about 1 ever when the patient's taking a breath. The only time it should go over is if you're doing a leak test. And then so as our patient exhales, you can see the CO2 absorbing granules. We use Nosorb here, and you want to refill those after 8 hours of use. So the Nosorb crystals, we refill them every week or after 8 hours of use, whichever comes first. Those absorb the CO2 from the patient as they exhale, because some of that air is recirculated back to the patient in a rebreathing system, which is what we have hooked up right now. So since they're rebreathing the air, you don't want them to be rebreathing the carbon dioxide they've exhaled, so it just scrubs that clean and sends it back to the patient. So we also have a reservoir bag, which is a reservoir for the air that's in the system. So that is a combination of kind of the O2 and the anesthetic gas. And it just kind of holds it there. It is a way that you can monitor the patient's breathing, is by watching the movements of the bag. You can also watch the inspiratory and expiratory valves to monitor their respirations. You can pick the size of the bag based roughly on the patient's weight, typically, or their relative lung size. So you want to look at their tidal volume. An easy way to do it is just take their weight in pounds times 30, and then round up to the next liter size up. So after going through all of that, this will go down all of our excess gas, the waste gases, go down to our scavenger, which is the F-air canister. So you just want to weigh that every day, and once it gets over 50 grams of weight gain, you need to replace that because it is overloaded on waste gas at that point. One thing I forgot to mention was the O2 flush valve, which if you hit that once you have your oxygen on, I have it turned off for demonstration purposes, it bypasses the vaporizer, and you can see it fill the bag as I push it too. So it bypasses the vaporizer and just injects fresh oxygen into the breathing circuit. Typically you wouldn't want to use that if you're actually doing surgery, because it's going to kind of dilute down the amount of anesthetic gases in the circuit. But you can put a little bit in just to help with manual ventilation if the bag is a little bit depleted. But yeah, typically you're not going to be using the O2 flush in a normal surgery because that could cause your patient to wake up unexpectedly. Hey, just realized I needed to correct something that I said before. I was talking about our carbon dioxide canister and accidentally said no Zorb crystals. Apparently it was late in the day. But we do use these Carbo-Lime CO2 absorbing crystals to refill that. So just to clear that up, it's not no Zorb cat litter. So we have a few different sizes of the breathing tubes, and we also have a discussion of rebreathing versus non-rebreathing systems. So over here we have a large tube that would be used on a rebreathing system. We also have our pediatric tubes set up to the actual anesthetic machine. So you just kind of want to use those based on patient size. A larger patient can handle a larger tube. A smaller patient would need the smaller tube. And then if you're dealing with patients that are under 7 kilograms or so, you would want to use a non-rebreathing system, which means that with each breath the patient takes, they are not rebreathing their own gases like they are on the rebreathing system. In a non-rebreathing system, the patient is getting fresh anesthetic gas and fresh carrier gas with every single breath, and with every exhale their air is taken directly to the scavenger instead of going through the CO2 absorber, because they're going to be taking in a fresh batch of air with each breath. With the rebreathing system, the air is cycled through kind of a circular circuit, so it goes through the CO2 absorber and then back to the patient throughout the procedure, so that they are rebreathing that air, and that uses, you know, the reservoir bag and the just tube coming off here, whereas the rebreathing system, which hooks up slightly differently, has the air going straight from the fresh gas port on the vaporizer to the patient and then out to the scavenger. There is a small reservoir bag there, which is nice because you can monitor their breaths, but they're really not rebreathing much, if any, of their air, and it requires a lot less effort on the patient's part, so that's why it's good for really small patients that don't have a very big tidal volume. It can also be used for really geriatric patients if they're small, or really young patients that are small. So it's less effort on their part. You do have to use a little bit more oxygen flow just to get the gas to them, and a little more anesthetic, but overall it's a lot safer for those small patients. So something else we have to help induce our patients into anesthesia are chambers, and we do a lot of exotics in this practice, so our chamber is dividable into smaller sizes in case you have a rat or a guinea pig or something that you need to anesthetize. You can put it in the smaller part to have a little bit less room for the gas to flow around since it's a small patient. You can also use these for fractious cats. We also have masks of varying sizes, so you would just hook this up to the anesthesia machine, and you would for the box as well, and then you can just push this over the muzzle of the patient, and that can help induce anesthesia if you are unable to place a catheter right away, to be able to give intravenous induction agents. You can use the mask or the box. Obviously it's a little bit less ideal. I want to place a catheter so that you have better control over the airway. You can start monitoring right away, but in some cases with a fragile animal, an emergency situation potentially where you just need them to start breathing gas so you can get them intubated, or with aggressive animals, you can use the mask or the box to help anesthetize them safely to keep the staff safe and the animal's well-being in mind. Okay, so we're going to perform a leak test on our anesthesia machine. So the first thing you want to do is close the pop-off valve all the way down. And then you want to occlude the end of the tube. I try and really get my thumb down in there and occlude every surface I can. Then use the oxygen flush to add pressure to the system, and you can see on the manometer it going up. So go up to about 40 and then just watch it. And it will naturally drop a little bit, but you don't want it to drop really fast or get below about 30 centimeters of water. So ours is looking good. It's staying mostly steady and it's stopping right there at about 40. I went a little over, but it looks like we're good on our anesthesia machine for today. We'll talk about the different types of monitoring equipment that we typically use when we're monitoring anesthesia. So I'll just go through one by one. We have our pulse ox here, typically clipped onto the tongue. It could also be clipped onto the prepuce or vulva or any area where there's no hair on the patient that's accessible. And that uses infrared light to measure both the oxygen saturation in the blood. You want that to be over 95%. And then it also measures pulse rate. So those are both really valuable pieces of information. Can talk about, it illustrates the tissue perfusion of oxygen in the blood. So we also have our ECG leads, and the white one goes on the right armpit. The black goes on the left kind of, axillary area, and then the red one goes in the left inguinal region. So the ECG will measure the patient's heart rate as well as the rhythm and quality of the heartbeat. So it's a way to detect arrhythmias. And obviously that can help a lot, knowing your depth of anesthesia or if there's any cardiac abnormalities that your patient is having. You may need to adjust accordingly with either chemical drugs given intravenously like atropine if you need to boost the heart rate a little bit, or decreasing or increasing the amount of anesthetic gas you're giving your patient. So that's valuable information. And of course, if there is some sort of cardiac abnormality, you may need to stop the procedure or rethink things a little bit. We also have our blood pressure monitor. I have a small cuff on here. So the way you want to determine your cuff size is you want the width of the cuff to be about 40% of the circumference of the patient's limb. Typically you're kind of putting it around the kind of forearm of your patient. If that's accessible, you can also put it kind of on the tarsus of your patient, and that will monitor the blood pressure of the patient, obviously. You can set it to automatically take the measurements, or you can manually take it, and it gives a good track record of how the patient's blood pressure is doing throughout the procedure. We have our capnograph here that connects to the breathing tube of the patient, and that measures both respiratory rate as well as the end-tidal and end-tidal CO2. So high end-tidal CO2 could imply that the patient is rebreathing some carbon dioxide and it's not being scrubbed efficiently. A high end-tidal CO2 could indicate that the patient is hyperventilating a little bit. That would cause the CO2 to go up. We also have our temperature probe. Here we use an esophageal temperature probe. So that just goes down the patient's esophagus and measures temperature that way. So you want to just make sure they don't get below like 98 degrees, 97 degrees ideally. Always have a warming blanket on them in most cases to kind of help with heat support on that. So those are all valuable pieces of monitoring equipment for monitoring anesthesia. Okay. So we're going to place an esophageal stethoscope in our patient. This patient is large enough that she comes out from under the drape anyway, but one of the perks of using an esophageal stethoscope is that you can place it with the patient under the drape and not have to disturb the drape that's sterile to listen to the heart rate. So you just want to take the plastic end and you kind of just move it alongside here. It won't go into the trachea since the trach tube is blocking it, so it will just go into the esophagus and then just listen until you can hear heart sounds.
Yeah. I got a text
And you
message.
should be able to hear both heart sounds and lung sounds.
Cool. All right,
And
thanks.
then you can
Doc,
assess
we'll see you, buddy.
heart rhythm,
Appreciate you.
rate, and strength,
All right, see you. Bye-bye.
as well as any breathing noises that there might be. So it's a great way to monitor a patient under anesthesia. Okay, so we'll talk about endotracheal tubes a little bit. I have a large one here and a small one just to talk about different sizes. A small one is typically used, for a small cat. Cats don't usually go above about a size 4.5 diameter. This is a 3. And then there's a size 9 here, which would be used for a larger dog. In choosing sizes, it can be based on patient weight. So, like a 20 kilogram dog maybe could take a size 8 tube, but it could potentially take a size, 10 tube, kind of depending on the breed and size of the airway. So you also want to take into account what breed they are. Are they brachycephalic? Often they'll take a size tube that's like 2 sizes smaller than a normal, like a large lab or something. So it's somewhat based on patient weight, but it's also based on patient's actual airway size. So you want to have a few tubes available when you're about to intubate a patient in case you need to go up or down a size, because you want it to be as tight as you can comfortably in the patient without causing any tracheal damage. And you want it to not be so loose in there that when you inflate the cuff, there's still air leakage going around it. So we have cuffed endotracheal tubes here. So you just take your little cuff syringe when you intubate a patient and fill it with air, and then just inflate the cuff at the end. So this is the end that's inside the trachea of the patient. You want to push the tube down just as far as it gets into the thoracic inlet and not any further, because you don't want it to actually go into one side of the bronchi of the lungs. And you want to also decrease, dead space. So ideally the tube length goes from just the basically the outside of the mouth or where the nose is down to the thoracic inlet of the dog or the cat. Then when you inflate your cuff, you want to keep it pretty soft when it's in the patient. It doesn't necessarily need to be as tight as it can be, because that can cause tracheal irritation. To check for leaks, like I just did, you can inflate it, and if you have time, you can store your tubes so that the cuffs are inflated, so you'll know if they're leaking over time, because if it's deflated when you go to use it, then there must be a leak. If you need to check quickly, you can just dunk that underwater and look for any air bubbles that would rise up. So that's how you would want to check for leaks. Obviously, you would want to do that before you intubate your patient, because if you have a leak when they're intubated, you could have problems with them waking up under anesthesia, and also just extra waste gas in the room. So those are all things to take into account when selecting endotracheal tubes for your patient. Okay, so we're going to be placing catheter into the cephalic vein of our friend Nikita here. This is Victoria, my preceptor, who's been helping me out along the way. So she's going to be the one holding off the vein for me. Nikita has been sedated. She's a little bit of a wild child. So the first thing is you'll want to shave a patch over the injection site. Hi, Nikita. Clippers are so loud. And we do shave all the way around the leg here, just to make removal easier. And since you're being such a good girl. It's hard on you too. Okay, then you just want to kind of gently wipe away all the excess hair. And then I have my Chlorhex and alcohol scrub, so you want to just do 3 of each. So a good soapy scrub over the injection site, followed by an alcohol scrub to rinse. And you want to do at least 3 preps to make it as sterile as you can. And you can check the gauze each time. She's a pretty clean little dog. So I think 3 will be sufficient to get that site nicely prepped for her. Chlorhex, another alcohol, rinse, our 3rd little Chlorhex scrub. Hello. And I don't do a lot of abrasive prepping. I've been told that it can cause a little bit more irritation the more abrasive it is. So, and she's a clean little girl. So we'll call that good. We have our 20 gauge catheter. And we have our prepped T-port. It's been flushed with saline already, and we have our flush here to ensure the patency of the catheter. And I have my tape around the side all ready to go. So we want to just open our catheter. And then we have Victoria stabilizing or holding off the vein so we have good pressure. And then just use the thumb of your non-dominant hand to kind of hold the vein in place. And then you can inject the catheter in at about a 10 to 20 degree angle till you see a flash. Advance it just a little bit further, and then use your finger to advance that. And then Victoria can kind of place her finger there to hold off pressure. You can pull that stylet out. Whoops. And try not to bleed all over the place. It's okay. You can use this to get that out of the way.
They're okay. She was worried about you.
And so we have one small piece of tape.
She's had a
You want to put sticky side up.
no other option. And so I was able to take the dog from her outside, not in the lobby,
Just wipe
and
that
I
off.
have the jet outside. They'll take me to the pocket with them in their face.
And hold it in place with your thumb. Twist that over the insertion area.
Basically,
Keep it as flat against the leg as you can. Then once that's pretty secure, you can go ahead and get your cap in place. So again, Victoria's kind of occluding the
Sorry,
vein.
babe.
It is okay. Literally a jump hazard.
And we have that in place. Now we have our tape with the notch in it. So we can put that under there. Makes a little window to bring that around. If it doesn't stick to itself. And then we can work on securing the T-port as well with our last piece of tape. Sorry, hold please. Here we go. Stickiness issues, we're all good. And then just kind of pinch everything down into place. You want to take your flush syringe, again it's just sterile saline, and make sure that your catheter is patent. So you can feel the vein above, and you can actually feel the fluid flowing in, and that flows really easily. So our catheter is in place. And then
Let me text message you that right away.
we'll just wrap it with a little
Okay.
vet wrap.
Okay. No problem. Okay. Where's those vet? North Branch.
And leave our little clip accessible and both of our ports accessible, and then she should be good with that for surgery. All right, so we're gonna put a catheter in the saphenous vein of our friend here. So just like before, you want to start by shaving the area. Go
Bless you,
over the
Daphne.
saphenous vein. You have a nice big vein. It can be a little harder to shave here just because of the way the skin is on the back leg over the bones. So just shave a pretty good area there. Get your hair out of the way. And then, just like for the cephalic catheter, you want to do a 3-way scrub. So we have our alcohol in our scrub. So you're just starting about the middle where you're going to be placing the catheter and work your way out in a target pattern like you would scrub for anything. So that was our chlorhexidine scrub. We'll do an alcohol swab. And we'll just go back and forth for at least 3 times to make sure it's as free of pathogens as we can get it. And you don't need to be really abrasive. You don't really want to irritate the skin since you'll want the catheter to be in place. And it'll be less to bother them, less reason for them to try and chew at the catheter if their skin isn't irritated. So that was 3 scrubs with chlorhexidine and alcohol. We have our 20 gauge catheter here. We also have our T-port that's been flushed with sterile saline. We have our flush syringe, and we have some vet wrap to wrap it at the end, and I have my tape up here. So he's doing so well. We'll get your catheter out and ready. Just gonna pop this so we don't have issues there.
He's falling asleep.
He's a good dog. And then you can see the vein here, so you're going to advance the catheter until you see a flash. And the saphenous vein can be a little tricky just because it likes to roll a lot. So you can see the flash of blood in the catheter, advance it a little bit more, and then you can advance the catheter all the way. And then you can remove the tourniquet, and the person holding the vein can hold there to avoid blood splashage. Take that little temporary one off. Put that there to hold that, so you can see there's good blood flow. Grab your first piece of tape, hold the catheter in place with your thumb, and try not to get all the tape stuck in their hair. He's a particularly hairy patient. You just want to get that wrapped around there. It's just kind of your first securing piece. And try not to bunch up the skin as I have done here somewhat. But I think we can loosen that a little bit. Sorry, buddy. So just lay the tape flat against the skin so the catheter stays in place, but you're not weirdly bunching the skin up around it. So we have our next piece of tape, the wider piece with a little notch cut in it. And slide that under. And secure that in place as well. Again, just pressing it against the skin, going around and getting it to cover where the catheter is meeting the skin. Try and get that out of the way. And then just kind of press down to make sure we're good there. Okay, I'm going to take my gloves off and get my T-port, just because I'm going to end up tangling myself. So we have our T-port here. We're going to take the sterile end off and this quickly to avoid any blood coming out, although it can be a little tricky if the tape is in the way. There we go. So we've got that in place, and then with our last piece of tape, we can get this so it's not going to kink. We can move this around so it's sticking up here, and you can seal that as needed. And then we just want our sticky side up. And can make a little cross around the whole T-port situation without getting too much of the cap. And it's always an adventure tying your T-port into place, but there we go. Secure, looking good. Get that. So our ports are in the same general direction. And then just kind of press everything into place. Before we put our vet wrap on, we'll just flush the catheter to make sure it is patent or patent, however you want to pronounce it. So you'll just have your saline flush, you plug that into the port. You can feel the vein above and feel that it's flowing. You would see like a bubble forming if it was just going under the skin. So it looks like we're in, it flows really easily. The catheter is good. And then we'll just put our little nice piece of vet wrap on to wrap it all up and keep it in place. Again, it doesn't have to be super tight. You don't want to cut off circulation. You just want to make sure it stays there and is still accessible. So there we go. We have our saphenous catheter placed. So we can do our sub-Q injection. So like for any vaccine or anything, you can just make a little tent with your hands and just go in, pull back, make sure you're in, and there you go. So we have an IM injection we can give. You just want to isolate the muscle and make sure you're not aiming towards the sciatic nerve that would run right along here. So I have her muscle isolated. It's kind of hard to see because she's so furry, but just go in, you can pull back, make sure you're not in a blood vessel, and there you go. So there's an IM injection. Okay, so we'll give an IV injection into the vein. So I have the lateral saphenous vein stabilized with a tourniquet, and you just want to enter into it, pull back on your syringe, make sure you're in, and then you can give your injection, and there you go. Yay! Okay, so we're back after 5 minutes of oxygenation for our patient, so we're about ready to intubate now. So we have access to his catheter here. I'm going to go ahead and flush the catheter just to make sure it's still patent. Hi. That's fine. So we're just feeling to make sure the fluid is flowing in there, and
Feels
that
good.
feels good. Thank you, Dr. Allman.
You're welcome.
Now we have propofol, which is our injectable anesthetic, and we want to give this to effect. So, it's okay, we can turn it off. So we just want to give about a quarter to a half of the amount in a bolus, and wait about 30 seconds and reassess, and see how much we need to give to produce the unconscious effect that we need. You're going to give about 4 mils to start. And,
Better give some more.
okay. Yeah, he's still pretty awake, so we'll give a boy named Sue some more propofol. So here's another 3 mils. You can see his head start to droop. He might be
You still got a lot of tone.
nearly ready. Yeah. Can check jaw tone.
Yeah, I'd give him a touch more. Or if you want to show him.
Yeah.
Jaw tone.
So I'm pulling down, and he's resisting quite a bit to me pulling down on his jaw. We'll give another 2 mils.
Perfect.
And I have 3 tube sizes in case the first one doesn't work. You can measure in a few different ways. You can go by the dog's weight. You can measure by measuring the area of their nose there to size. So I've chosen a size 10 tube. I've checked the cuff for leaks, but we'll do it again once he's intubated. So, thank you. So you just want to go in, you push down the epiglottis until you can see the arytenoids spread, and then just advance the tube, and you have your tie ready to tie around. Tie it tight, and then you can tie around the muzzle. Okay, and so we have our patient intubated. We want to inflate the cuff, and you want it just enough so it's a soft pillow of air, not so much that it's so taut that it could cause tracheal damage. So that feels pretty good. Once we get them hooked up to the anesthetic, then we can check for leaks. So we'll hook up the breathing tube, have our oxygen ready and on. We're using Sevo. We'll start him at 4 on the sevoflurane, and then we're going to give him a breath and listen. So you
want,
can,
you want to listen and I'll give him one?
yeah, that'd be great. I didn't hear anything in that, but it would definitely be easier if I could
Okay.
get a little closer. So you can listen for an air leak. You can also smell and see if there is any Sevo
Okay.
leaking out. And I don't hear anything. I don't smell anything. I think we're good. So we're good on the cuff inflation. We'll go ahead and lube his eyes, and then we'll get him ready for our procedure today. So again, the eye lube is just because they don't, you know, produce much secretions. Whoops, sorry, buddy. When they're anesthetized due to the different medications that they've been given pre-anesthetically. So we just want to keep their eyes moist. Okay, so he looks good. There's no leaks, and we're ready to position him and start our procedure. Okay, so we have our dog here that we're going to be spaying today. So we're going to do our whole pre-surgical clip and prep. So the first thing you want to do is try and palpate for the bladder and express if needed. I did take her out for a little potty break before surgery, so you want to just palpate. Oops, there goes that. And her bladder is very small and pretty much empty, so we don't think we're going to get anything out there, but it's good to just check and feel. You don't want her to have to urinate during surgery. So now we'll start spaying for our spay. And for any surgery, you just want to talk about the margins that your doctor wants for a spay or for any other procedure. Because after you've prepped, you don't want to have to go back and clip more. Try and make it look somewhat symmetrical and even. You can go with the hair and then against the hair for the final clip. And just be careful not to snag any skin. It can be kind of delicate on their bellies. You happy with those margins, Dr. Savageau?
That looks beautiful.
All right, we'll
We're
do
ready for
our
you to go
vacuum.
home from treatment. EC, ready to go home.
Okay, and then I have my alcohol and scrubs. So you want to do at least 3 scrubs followed by alcohol. Oh, that's just a little bit. I'm actually going to clip that just a little bit more right there. All right, there are a couple little hairs that were bothering me. Okay. You want to put gloves on as you prep. Keep everything as clean as possible. And then you want to do 3 rounds of prep and alcohol at minimum. She's a fairly clean little dog, so 3 should be good for her. You can kind of bunch your gauze up into a little square and start at where the incision will be and just work your way out in a target pattern. And anything that touches the hair on the edge will be discarded. So, all the way out to the edges. So that was our scrub. Now we have an alcohol prep that we'll use as kind of a rinse, same target pattern. All the way up and around and down. And we're using chlorhexidine scrub. And you don't have to be extremely abrasive. That can actually lead to a little bit more tissue sensitivity that we don't really need for our surgical site. Just kind of want everything to be clean, but not irritated. Okay, so that was our second round of alcohol. We'll do one more of the Chlorhex scrub. And then one more alcohol, and then we'll be ready to move her into surgery. So one more alcohol rinse. Get all the hair pushed down and away. And then we can start dismantling some things. We'll have to detach her from the anesthesia machine last thing. So we're gonna have to unhook some of her monitoring things really quick just to get her ready to move. And then the last thing we'll do will be to unhook her from the anesthesia machine. So we'll just turn off the SIBO, turn off oxygen, disconnect her tube while she's still so there's no tracheal damage. And then we can use this towel as a sling, and you just want to maintain the sterility of the surgical site as best you can. If needed, we can do a final prep. So you really want to support the head with the tube. Since they're, obviously not able to move, you want to avoid any trauma to the neck or the spine. Okay. So first we'll get her hooked back up to anesthesia, and then we'll want to secure her to the table. Thank you, Tiffany. Get the SIBO turned back on, get the oxygen turned on. We have our leg ties ready. And you always want to secure your patient to the table just in case something were to happen and they were to suddenly wake up under anesthesia. You don't want them to jump off the table. And then Tiffany's hooking up some of the monitoring equipment, and I can go over that as well. I'll put them on, yeah. Thanks. We got all her legs nicely tied. I like to do kind of a double loop so there's no tourniquet effect on their extremities. I'll get that in just a second. I'll finish hooking her up to monitoring. We will do a final prep in here. So we have our ECG with the white lead going in the right kind of inguinal area. Black goes on the left and red in the bottom here. Try not to touch the surgery site with anything. And try to make it so it's not pulling on them. So I like to prop the weighted end up on the table so that there's no pull on their skin. Tiffany hooked up our blood pressure cuff up here on her forelimb. And then let's see what else we got here. We have our pulse ox, so that works well on the glove. On the tongue. And we have our monitor set up, so it's already starting to record the values as I hook her up. With the ECG leads, you do want to spray them with a little bit of alcohol so they read. And you don't want hair on the end of it. We have our temperature probe. Again, it also has a little clip on it, so you can clip that to the towel so it doesn't slide back out of the mouth. That just goes down in their esophagus. So you can just pass that through, and you can kind of see values come up as it begins. For the blood pressure, I'm going to go ahead and start that, so that we'll have a value to read as we monitor. Everything else looks good. She's breathing well. You can actually see the bag move as she breathes, so that's a value you can record without even having to necessarily look at the monitors. Respiration rate just by watching the bag. We also have our capnograph that's attached to the tube, so that was already in place when we put her in here. And then I have our monitor sheet here. So we'll start monitoring now. We have her oxygen percentage is at 96. Her heart rate is at 88. at 10. Capillary refill time, you can check on their gums or on the inside of their lips. So you just want to push down and see how long it takes for the white color to become pink again. It's typically less than 2 seconds. She looks good. Her gums are a good healthy pink color. Her temperature is 99.9. And blood pressure is reading at 99 over 49. 99 systolic, 49 diastolic, with a map of 66. So we'll monitor her on our sheet every 5 minutes. You also want to write down the SIVO level that she's on, which is 3. Our oxygen's at 2 liters per minute. And we'll hook her up to fluids right after this video. Okay, so we're going to demonstrate CPR on our small little patient here. You would want to start CPR at the first sign that you suspect the heart has stopped. So if you are, listening for a heart rate and you're not hearing anything, then you want to start CPR right away. You want the patient in lateral recumbency, legs facing away from you. For a larger dog, you'd want a two-handed approach and to compress at the thickest part of the chest at a rate of about 100 beats per minute. They always say to do it to the staying alive, so and compress down about 1/3 to 1/2 of the chest width. If it's a brachycephalic breed, you can do it in dorsal recumbency just because they have a thicker chest and compress that way. Also, for a small patient like this or for a cat, you could attempt a one-handed compression if they're pretty small and fragile instead of compressing so hard that is going to really damage them. You also want either of them hooked up to the anesthesia machine. If there's no anesthesia machine, you're the only person around, then you'll want to compress at a rate or at a ratio of 30 compressions to 2 breaths through the nares, so little breaths into the nares, inflating the lungs. So 30 compressions, 2 breaths, 30 compressions, 2 breaths. Listen after 2 minutes of work. You want to do this for 2 minutes at a time, unbroken compressions, and then check for heart rate again. If you don't have an anesthesia machine, you can also use the ambu bag. So you'll just hook it up to the tube. We're pretending he's intubated. If you have someone that can give breaths, they can just squeeze that. You would see the lungs inflate at a rate of about 10 breaths per minute. You don't want to give so many breaths that it's not really helping them in that way, and so few that it's not helping. So 10 breaths, 10 to 12 breaths is about the magic number to give. So if you have someone else, ideally they are giving 10 breaths per minute while you are compressing for 2 minutes. 100 beats per minute. And then you can switch out with someone else. You can trade jobs after 2 minutes after you've checked. And that is your basic CPR. And hopefully your patient starts showing signs of life again soon. All right, so we're gonna get ready to scrub into surgery. The first thing you wanna do is thoroughly wash your hands and forearms. So get a good bit of soap and then kind of just wet everything. And try and keep your hands above your elbows so the water all runs back down and then just drips off, and that's okay. You want to get under your fingernails, in between your fingers. This is just a wash, not a sterile prep, so we just want to get everything washed. Down to the elbows, don't come back up. Rinse everything off. Again, hands down. Still kind of soapy. I'm going to do a second rinse. And then again, it's okay if it just drips off. Try not to get too much on your scrubs, but then you can grab your sterile towel from your pack. Just sure not to touch anything else. Don't let it touch your scrubs. And just pat yourself dry. Again, always working hands down to elbows. And then for our scrub, we're going to use Avogard, which is a rub, so you don't have to scrub and use water like you would for other surgical scrubs. So that's just here on the wall. Again, I'm just trying not to let my hands down, not having them touch my scrubs or anything. We have a little foot pump, so you don't have to hit anything with your hands. And you want to get your fingernails in there on both sides, so you can kind of rub them together. And then you're really just rubbing it in almost like hand sanitizer, but that works better. In between all your fingers, and then just just like the scrub, go all the way down to your elbows on both sides. And then you kind of want to let it air dry for a minute, so we can stop the video. Okay, so we've had our contact time that's required for AvaGuard, at least 5 minutes. My hands are feeling pretty dry, so we just want to take our gown and you hold it up, step away from the table, and don't shake it too much. You just want it to fall open naturally. And you can spread your arms, make sure you don't hit anything. They're extra large gowns, so it's a bit of a challenge when you're smaller. And just have someone tie you in. You can get over to your gloves. We're going to do a closed gloving. So just open those up through your gown. And then get your fingers kind of close to the edge, lay the glove down. You're kind of pinching it with your hand that's on the inside of the gown. And then just kind of work that up, flip it around, pull it. You can kind of adjust as needed through your gown. Okay, other side. Lay it down flat on your palm. Whoops, don't let it fall. Get a good pinch on it. Grab your cuff of your glove and flip it around like that. And staying over my surgical field or my sterile field, but not letting anything touch the table. Pull that. Okay. And then you can kind of adjust as you go, but that's the basic idea of closed gloving. And so now we can head into the surgical suite and we'll get started with our patient. So now we are in surgery. We have our patient, we have our pack open already. We had an assistant open that while I was getting scrubbed in. So we want to take our instruments. We have the suture and the blade that we're going to use here. So we're just going to set that off to the side for a second. We do have our steri strip in here showing us that the pack is sterile, so that's good. We have our gauze, which we'll also just put in a little pile over here to be used later. And then we have all our instruments pretty lined up already. The towel clamps we can set out first because we'll want to clamp the patient in if we need to. We have the spay hook that's kind of tying everything together, so we can take that. So all the instruments are ready to be used. We'll put that on the side. Just going to turn the forceps towards where the surgeon will be so she can easily grab them. And we have our scalpel, so we'll put our blade on. You want to use needle drivers to put the blade on because those are what is supposed to touch metal. There they are. So we have our needle drivers. And we're going to take our blade. You don't want to pick up the blade with your hand. And you can just slide it on like that. So we have our scalpel ready to be handed to the surgeon. We're just going to set that so the handle's towards her when she comes in. We have our drape here. So let me find my scissors here. So we're going to estimate where we're going to want to cut our hole because once you have it on the patient, it's not considered sterile anymore. So I have it opened up to about the middle and then one of the middle folds here. And so we're just going to kind of isolate that spot. And cut a size that should fit the size of our patient. And once it's on the patient, we can move the drape forward or back as we need to. It is kind of tricky because you don't want the whole drape to fall open and unfurl and fall off of the sterile field. So we've got that, we've got that. Now we have our drape. And I may need some assistance just getting the drape on the patient without contaminating anything. So I just want to spread it out. Or do you want to take that side close to you? Okay. Excellent. And then we can just lay it down on our patient. Just making sure, of course, not to touch the patient while we did it, which I think we were good. I didn't see any breaks in sterility. Made sure not to touch our paw or the towel or anything. So we just want to keep our hands kind of at chest level. We may move the drape as needed, but for now I think we're pretty set for surgery on this patient.
Chelsea, can you hand me a hemostat?
Sure.
Thank you. Thank you. Chelsea, can you hand me a scalpel blade?
Sure.
Thank you. Chelsea, can you grab some gauze and
Sure.
dab right here?
What's that?
Right there on top of the hemostat and the pedicle right there. And then right in the abdomen right there. Perfect. Thank you.
Welcome.
Can you hand me the thumb forceps as well? Perfect. Thank you so much. Okay, can I have some moistened gauze, please? Would you
Sure.
mind moistening these intestines right here? Thank you so much. That's just some sterile. Perfect. Thank
Good.
you. Great.
Okay. So the basic duties of the technician during surgery are to anticipate the surgeon's needs, handing them instruments they may need or handing them ones when they ask for them. Also maintaining hemostasis, so blotting tissue, looking for bleeding, as well as aiding in retraction and visualization. If the surgeon needs a better look, you can use instruments to help hold the abdomen open or whatever surgery they may be doing. So those are the main duties of the technician, but the main thing is to just anticipate the surgeon's needs and be ready for anything they may ask of you. To stay sterile, obviously you don't want to touch anything like the patient or the table or anything that is not covered in a sterile drape or within the sterile pack that's open. Anytime any instruments gets dropped or anything, they just stay down. Also always have extra peel packs of things ready to be opened if needed. You want to keep your hands kind of at chest height, so just between your shoulders and your waist. And any breaks in sterility, the person would need to back away from the table, take off their gown and gloves, and just do the whole thing over again. Maybe not a full scrub, but at least a new gown and gloves for any break in sterility. So those are the main things to do when assisting with surgery. Okay, so we're just going to shave the neuter site for our canine neuter patient. Okay, we are neutering this little kitty today. Okay, so here we are doing a feline spay. All right, so we're done with surgery today, so we just want to do a good clean of the room. We have our towels we used for our patients, so we can get rid of those. Make sure they're all unclipped from things. And then we have a special tub just for surgery laundry, so they'll go in there. We can turn off our heating pad. And we'll clean that and put it away. And we want to clean off all the monitoring equipment and get it all put away. So I just use a little bit of alcohol, especially on the ones that went into their mouth, obviously, but it's good to wipe everything down. So we have our pulse ox. Just want to get all surfaces of that might have touched their mouth and down the cord a little bit. Check it if there's any blood or anything. Sometimes there will be if they're used for a dental. You can wipe off the ECG leads. Pretty much anything that really touched the patient that could have any residual blood or debris on it. Fur, just kind of check all the surfaces. So everything gets wiped down. Where did our temperature probe go? Well, we'll get our capnograph. That was close to the patient's airway. Be gentle with that, as it is a surprisingly expensive piece of equipment, so don't let that crack against the floor. And okay, our temperature probe that was down in the esophagus, so give that a good wipe down and just check everything over. We also will want to wrap every piece of equipment up and attach it back to the side of the monitor. I'm not going to show every single piece being wrapped up, but basically just make things neat and tidy. We have these hooks over here that we'll put each one on. We have little strips of Velcro to keep everything together, so I'll come back and do the rest here in a bit. We can throw this away. Okay, so we have our rescue disinfectant that we use for our surfaces. So you'll want to spray down your eating pad and make sure you get that well covered and all the little grooves and everything and out on the edges to get that clean, because the patient was on a towel but laying on it and things could have soaked through the towel and be on it. That can then just get carefully put to the side. Pick up anything you drop on the floor. You'll want that back where it was tomorrow. Spray the table down, and then basically just wipe any surfaces. So the surface of the monitor. Look for any blood spots. The Mayo stand that the surgeon used to put their pack on needs to be wiped down. And really just any surface can use a good, quick, just little damp mop with the spray and a paper towel. I'm gonna check the edges of the table, make sure nothing dripped over the side. Okay, and then you'll want to take the trash out. And any sharps, we already got rid of the sharps from the pack, the scalpel blades, but we do have a sharps container over here. So any sharps you encounter during cleanup will want to go into a sharps container, not into the trash. So we'll take our trash out. And then we'll start getting ready to vacuum and mop. We vacuum and mop at the end of every day, so you'll just want to pick up anything that's on the floor, any little bits of trash or whatever that the vacuum won't pick up. We'll come back to show vacuuming and mopping later today. Okay, so we vacuumed, and then, you know, we just want to mop the floors like we do every night, and just kind of mop your way out of the room so you don't step over where you just mopped, and our room is clean and ready for tomorrow. Okay, so we have our instruments from our pack from spaying our dog. Pre-soaking in here is just water, distilled water with a pump of the Miltex instrument cleaner. So I've let those soak for about 5 minutes. I've opened up all the box locks so it can really soak into every little nook and cranny in there. We have a soft bristled brush that we'll clean the instruments with. So each one, so like the ridged little hemostats and stuff, you want to really just make sure in each ridge you've gotten all the blood. Check your box locks and really open them all the way to see if any blood or anything remains in there. So each instrument is going to get the same little wipe down, not too abrasively with the brush. Hopefully the pre-soaking has gotten most of everything off. So all your little forceps, all your towel clamps, just check each one really carefully and make sure that there's no debris remaining. So the second step after we've cleaned all the instruments is to load them into the ultrasonic. You can see there's water in there. It's distilled water mixed with a little bit of the ultrasonic detergent. So you just want to put the lid on that and turn it on for about 10 minutes. And that will further knock loose any particles that are remaining in any of the spots I couldn't get with a soft bristled brush and leave everything super clean. All right, so we have our pack all laid out with the box locks open, and then we have instrument lubricant or instrument milk that we just like to spray the instruments with and make sure you get in all their locking mechanisms to keep things lubricated. Okay, so we have our pack that we've washed and lubricated and let air dry. It's arranged with the instruments, largest to smallest. There's 30 pieces of gauze that have been counted out. We do that for all of our packs, and then there's also a steri strip inside, so that will turn black in the pack once it's sterilized, and it's open to ensure that the pack was truly made sterile in the autoclave. So to fold our pack, we're going to fold the top down first. It's a little bit difficult with the rectangular tails and the kind of, or towels and the kind of square pack, but you just want to leave a little flap there, basically on every side. So the flap kind of like makes an arrow as to which direction you'll pull the towel when the pack's being opened. And you want to get it as tight as you can against the instruments, so there's not a lot of just air space in there. Fold one over, make it look nice, and leave a little tab out. Have another clean towel, and you'll just do the same thing over again. Carefully moving the pack so you don't jostle things around too much. And you can go the exact same way, or you can go the opposite way. But in any case, you just do the same thing over again. Double wrap it. And then that way you can open it for the surgeon and there's still a sterile layer inside. Tuck that in a little bit more. Okay. So, getting everything all tucked in there. There we go. All right, so you've got your nice little envelope fold. Get any little pieces that might have picked up on there. We have, we tape our packs shut with regular masking tape. And then we'll put some indicator tape on it as well. But because the indicator tape is somewhat expensive, we don't like to wrap the whole pack with it. So on just the regular masking tape, you will put the name of the pack. Here we go. We label our packs by the color of the instruments or the bands that are on the instruments. So this one's called the rose gold pack because the instruments are a rose gold color. So rose gold pack, the date, and initials. And then put your piece of indicator tape. And you can see the stripes on the indicator tape that are white now. Once they come through the autoclave, they will have changed color to ensure that it's sterile. So that can go wherever on the pack that you want. And then it's ready to load into the autoclave. So we'll head this way. So this, we load them pretty lightly. You don't want to overpack an autoclave. You really don't want the pack to touch the sides, and you don't want it to be overcrowded. So we'll usually do just one pack at a time. There are multiple layers, so you could potentially have a pack and have some gauze or have another drape that you want to sterilize and a layer under it, but the idea is that you want steam to be able to get around the entire pack, not have anything pressing against it, so that it can penetrate thoroughly. So in here, there's distilled water that it's filled with, and it will have a little alert if we need to fill water, which is not on now, so we're good on water. And so as the autoclave runs, pressure builds inside, usually 15 to 30 psi, and the water heats up to about 250 to 270 degrees, so it's steam. And that pressure and steam is what pushes into the pack and kills any bacteria that are remaining on the instruments after all of our best cleaning efforts. So it's still going to do a lot better than running it through the ultrasonic, and it's going to actually sterilize the pack. So we'll close our door, tighten it down. Pretty tight, not too tight. Our little light came on to ensure that the door is closed. We're good. It's set to the setting that we keep it on for everything here, for all of our packs. So you don't have to worry about changing the setting on this particular autoclave. And then you'll just hit start, and you can come back in 30 minutes. It'll pop itself open so the steam will come out and evaporate, and you should be good to go. Okay, so we're going to be folding our gown for a sterile gown pack. I have the gown laid out with the sleeves facing in. So we're going to take one side and just fold it to meet in the middle, straighten out the edges, and tuck in the little ties. And then take it again, fold it in that way, straighten everything out as best you can. I'll just walk over here and do the other side. So same story on this side, fold it into the middle, straighten things out on the corners, and tie in, make sure those are in, and fold it in again. So we have it folded in, so everything's meeting in the middle. I'm going to do one more fold just to make it small enough to fit into our towels that we wrap the packs in. And make sure our ties are in there. And then you just accordion up from the bottom. You can get it to sit nicely. And then turn it up. So right now the gown is facing, the inside of the gown will be facing you when you open it, and you'll have little pockets to put your hands, to put your, to get the sleeves in. And we put a towel in here for drying your hands, and a steri strip as well that will turn black once it's gone through the autoclave. And then this is just wrapped like our packs are. So just a little envelope fold. Closed all the way. There we go. And,
Go.
And then we will fold our over in the same way, just like we fold our instrument packs. Leave a little tab to pull as it gets opened. The little tabs make a little arrow, so you will pull it that way as you're opening it. Makes it a little easier to open it and keep it sterile. And so there we have our little fold. And get it all nice and straight on the edges. And then we'll just put some tape on there. We'll just use regular masking tape for our labeling tape. And then we'll put some autoclave tape on, which once it goes through the autoclave, the little strips will change color so that you know it's been steam processed and is sterile. So we just have these little strips of autoclave tape. You just need to get off enough so a few stripes will be on there, so you'll be able to tell that conditions are met for sterility. You can put that wherever, and then you just want to label with the contents of the pack, so gown, and then the date, and my initials, and we're ready to go. Okay, so as for general autoclave maintenance, we do like to take everything out, the trays and everything, and wipe it out at least weekly. So any kind of residue that's built up can just be wiped out. Of course, you always want to keep the water level good. That's before you're going to run any pack, so there should be an alert, but you can also pop this off and check the water level yourself to make sure there's enough water to run your load. There's also the Chamber Bright Autoclave Cleaner, so we do that once a month and just run a load with this powder in it with everything all emptied out, and that will cleanse the entire inside of it. And then there's also filters. There's various filters in the back. It's heavy. I don't really want to pull it out right now to show everything, but there's filters that you can pop out, clean those, and you can do that monthly, as well as when we run this, we also will empty all of the water and refill it with fresh distilled water. So those are all our monthly things. Weekly, just kind of wiping it out and, generally keeping it, full of distilled water for your packs to run. And that's basically your general autoclave maintenance. Well, after I ran my pack through the autoclave, I did not work the next day, so that pack was used again and re-autoclaved by someone else. But to get the idea of how to know a pack is sterilized, I'll just show a different one. So this is just another pack that we have. You can see the stripes on the indicator tape are now black, so that is how you know that it has been run through the autoclave and should be sterile and good to go. And then there's also a steri strip inside, so you can know that the steam and pressure penetrated all the way through the pack. Of course, I'm not going to open the pack, but that is a way you would determine true sterility inside the pack. Okay, so we're going to do a suture removal on our little friend Fern. She actually fractured her radius 2 weeks ago and had that repaired, so she's here for suture removal. Her incision looks great. It's kind of hard to see there if we can swing the camera around. one suture got removed before the video started, but so things you'd want to look for on a suture line that might not be good would be, you know, redness, swelling, discharge coming from it, obvious pain from the patient, things like that. So hers looks great. There's no swelling, there's no redness. It looks beautiful. Hi. So these are continuous sutures. You can kind of just snip each one and pull with your hemostat, or you can use forceps if that's easier for you. But we do have some hemostats reserved just for sutures. You can either kind of unhook or just kind of go down the ladder. And then you can take each one and pull. And you want to reduce the amount of suture that's going like through the skin, so not have a big tail hanging out that's going to drag through all of her fur. And she does have some Demodex mange, so you definitely want to reduce the amount that's being dragged under the skin there. And she's being so good. Oops, sorry, pinched your skin. And then we'll just get this knot at the top. And there we go. And it looks good, no scabbing, no irritation. And so we'll just tell the owner to keep her e-collar on for another couple days to make sure she doesn't bother it, and she should be good to go.